So anatomy around the shoulder joint. So we have our humerus, which articulates with the glenoid surface of the scapula to form the glenohumeral joint. We then obviously have our clavicle coming across, which communicates across at the top at the acromioclavicular joint with the top of the scapula, the acromion. And then the muscles that hold around the shoulder. So we're looking at the rotator cuff. At the front we've got subscapularis, which is responsible for internal rotation of the shoulder. Across the top we have supraspinatus, which is responsible for abduction of the shoulder. And then round the back we have our infraspinatus coming down across onto the back of the scapula, and teres minor, which are responsible for external rotation of the shoulder. So at the front of the shoulder we've also got the biceps tendon that passes through the groove at the front here, the bicipital groove, and then obviously passes underneath the rotator cuff through down into the arm. So if we're examining the shoulder joint, first of all in standing we can have a look at the positions of the scapula. So we can see in this position here that the scapula is nicely placed against the border of the ribs, that the shoulder is facing forward, and we haven't got too much of a downward tilt of the shoulder blade here. In some conditions, like a long thoracic nerve palsy, we'll see that this border of the scapula starts to lift away, and that's true winging. On a lot of the patients we see, we start to see some pseudo-winging where the inferior angle of the scapula lifts away just slightly. So in this position, we've looked at the shoulder position. We can then start to look at some of the movements of the shoulder. So if I ask Matt here to take both arms above his head, so if he lifts both arms up into the air, we can have a look here in terms of the control around the joints here, but also in terms of the range compared left to right. And the back of the markings of the shoulder can give you a little bit of an idea about the symmetry between those movements. We come back down so we can look at the movements through flexion into elevation, but also through abduction into elevation. So if we get Matt again to bring his arms out to the side and lift overhead, so coming right up across the top of his head, again we can compare the movements between left and right. And you might see here there's a subtle difference in range on the left to the right side. So if we bring arms back down, from here we can look at lateral rotation. So if I turn Matt around, so face the camera. So if we look at any capsular restriction around the shoulder, then we're looking at the range of the shoulder here. So in this position, we can easily look at lateral rotation. So look at the range, and the range of motion should be about 70 degrees in this position. And then feeling that end feel to make sure it's nice and soft, and then moving back and obviously comparing left to right. So if we're looking at medial rotation or internal rotation of the shoulder, if we turn Matt round and ask him to place his hand behind his back as far as he can go. So if we can reach up in between the shoulder blades there, so you can see the range there from the left side, and again we can compare that again with the right side. And normally there's a little bit of asymmetry between dominant and non-dominant arms. That's great. So if we turn you back round, in shoulder conditions, often what we find with a capsular pattern is that we have more restriction of the lateral rotation, greater than abduction, and then medial rotation. So on looking at those range of motions, we can actually look at some early testing around the shoulder in these positions. So looking at Matt here, can he pull his hand into his tummy, so we can hold and resist that movement there. So we're looking for the strength there compared to left and right. And the same with actually getting Matt to hold there, and he can also push out against my hand, and we can look at the strength of the external rotations in that position. For people that have quite a lot of restriction, and perhaps some of our elderly patients, sometimes those positions are a little bit more difficult to get into. So we can then look at things like Napoleon's test. Now with Napoleon's test, if I get Matt to place his hands onto his hips here, what we should see here then is if he pushes into his hand here, we should see easily being able to lift the elbows forwards. In a significant rotator cuff injury, that would not be possible to do. Again, also if we turn around and we look at the hand behind the back, in this position here, with a good functioning cuff, we should also be able to lift the hand away and hold that position without dropping against, as you can see, that Matt is able to do there. Again, in a cuff that's not functioning well, particularly across subscapularis, that will be difficult to do. So if we're going to palpate around the joint, we can feel across onto the head of the humerus, and then we have the ability in that position, you can actually do some forward and backward glides if you wish to progress onto those. You can come across off the shoulder here, and we can come across off the end of the border of the clavicle here, and we're across onto the acromioclavicular joint there. Again, with a lot of the resisted testing, we can also palpate across the cuff from behind and also at the front in terms of subscapularis. So looking at some additional tests, we'll start to look at perhaps more the strength and the impingement risks around the shoulder. So if I lift Matt's hand up to here, we can look at the full can test. And in this position, I can get him to push against my hands, so looking and feeling for symmetry and strength in this position and the absence of whether there's any pain or not. From this position, we can move quite quickly into empty can, which looks at more of the internal rotation impingement risk. And then we get to push against my hands in this position, and we again can look for strength and the presence of pain in those positions. We can also look at Hawkins and Kennedy test, which involves me bringing the arm up to 90 degrees, fixing across the back of the shoulder blade here, dropping the glenohumeral joint into medial rotation, and then coming across into adduction and seeing if there's a presence of any reproduction of symptoms in that position. And that's Hawkins and Kennedy test. In this position, a similar position to that, we can also look around the acromioclavicular joint and see if any compression of that joint also reproduces any symptoms. And by that point, we can look at scarf test, whereby we move across into adduction and we have a very firm press into the end of range there and then back. And as you can see, that's got full range and no pain, so that's a clear test. So looking at instability testing, in sitting, we can have a look for a sulcus sign. So in this position, I can add some distraction at the base of the humerus while feeling across the joint, and you're looking to see if there is a presence of a sulcus as we distract down through the humerus. If we go over into supine, so we just get Matt to have a lie on his back for me again. So coming into line on Matt's back, we can have a look at an apprehension testing. So we can take the arm up into 90 degrees and feel as we take the arm into rotation. You can support across this joint, so as soon as you start to go into a lateral rotation, you can feel if there's any sort of tightening around the shoulder or apprehension from the patient, and then apply some pressure to take that off and relieve off to see if that changes the range of motion or the feel of the movement. So if we have detected some tightness within the capsule, particularly into lateral rotation, we can use some very simple stretches to address this. Now, these can be done in varying degrees of abduction and can involve some pressure of taking the arm into rotation from in that position or even across to place the hand underneath the pillow and getting the patient to work on letting that elbow drop down in the extremes of motion. So those will be to stretch external rotation and a capsular restriction. For restriction of medial rotation, we can look at an exercise which is commonly called the sleeper stretch. For the sleeper stretch, you get your patient to have a lie on their side. In this position, you can nicely support under the elbow with a towel or a hand if you're the practitioner performing it. And you can drop the elbow into rotation, internal rotation, until you feel a stretch. Can you feel that, Matt? Yeah. To further maximise the stretch, if I ask Matt to roll across towards me, so just rolls forwards, he can further increase that stretch just by rolling across. And that should stretch over the back of the shoulder and into internal rotation. So for some early strengthening exercises for the shoulder, we can use some TheraBand, and we can look at doing some rotation work in standing. So particularly looking at working on the external rotators, which are commonly weak in shoulder injuries. If we look at this position here with Matt, we can take the elbow out to the side, and then if I get him to then bring his hand out towards me, so the rotation is coming through purely through the centre of his elbow here, down through the shaft of his humerus, and he's pulling out into rotation. And if we then turn Matt round, we can also equally look at internal rotation. So the same thing here is to get Matt to think about bringing his hand over towards his tummy. And as you can see from the back here, the elbow staying nice and still and he's just pulling across to strengthen across the front of the shoulder. So if we're going to strengthen into internal rotation, if we look at the left arm, and then we can actually get Matt to think about pulling across to his tummy here, and then releasing back with good control. So again, elbow staying nice and still, just rotating through the elbow arm here, hand comes to the stomach. Nice control through the shoulder blade here. And we're looking at these being something in the region of 8 to 12 reps and 2 to 3 sets to improve our muscle strength.